of the Uplift Peer program that we're starting here at UND. I'm a senior at UND, just got my CFI. Shout out to Jeremy for doing my final check. This is Mark, our vice chair, and we'll be moderating our first panel here. So we're just going to start with some introductions, get the panelists to introduce themselves and what their role is in the SI and FAA medical process.
Okay. Can you hear me okay? Is that going? Okay. My name is Mark Christensen. I'm a family practice doctor. For the last 25 years, I work right across the street at the Student Health Services. I've been doing flight physicals as an AME for about 20 years now. As a group, we do close to 1,000 flight physicals a year. They keep us quite busy with the flight school here. So we're very in tune with what's been going on, and I'm looking forward to a good conversation today.
Hi, I'm Quay Snyder. My role is as the ALPA Aeromedical Advisor and also the FAA ALPA HIMSS Program Manager, using education as a tool to help with drug and alcohol addiction, but also with mental health. My background is I went to school at the Air Force Academy back when dinosaurs roamed the earth, and was a flight instructor there, became a flight surgeon. Had wonderful opportunities in the Air Force, both as an instructor pilot and a flight surgeon. Joined our business, the Aviation Medicine Advisory Service, about 29 years ago, and have been working to help pilots maintain their medical certification, but also to affect FAA policy and international policy. So our office takes about 250 phone calls a day from pilots all over the world, and submits about 4,000 waivers a year to the FAA for pilots to help get special issuance in all fields, but also in the mental health area.
All right, guys, can you hear me okay? Daniel Danzig, Federal Aviation Administration. You don't see my nice photo mug up there. I just found out to be here about 48 hours ago. But I want to tell you a little bit more about myself. I've been at the FAA now just under 12 months. I actually came from Mayo Clinic. So I'm one of the assistant chief psychiatrists. I'm the third psychiatrist to join headquarters. Prior to being there, I was a HIMSS AME and HIMSS psychiatrist at Mayo Clinic, and have been practicing occupational psychiatry for approximately the last decade. I'm also the state air surgeon for Minnesota. We'll be soon going back to one of the wings to take over as an SGP down there. Part of what I do up at headquarters, we've been actually quite progressive this past year with some additional policy changes, which you guys will hear more about. But I hope to give you guys a unique perspective that I've learned crossing over to this other side on actually reviewing the certification process now. So.
Hi, good morning. My name is Michael Wolff. I'm a physician at Mayo Clinic, aerospace medicine physician. I have a little bit of an unusual background. Started my career as a paramedic, worked for the city of New Orleans, and then out in California and with one of the federal disaster teams. Went back to college a little bit late, finished my undergraduate degree, medical school at the Uniformed Services University, the military medical school. Spent my entire military career on the operational side in carrier aviation and with the test community, deployed on an aircraft carrier. I like to say I flew everything that takes off and lands on a small flight deck. And came to Mayo after I got out of the Navy in 2019, and I'm a senior AME and HIMSS AME. Our practice, we take care of all types of flight physicals, but I would say that our bread and butter are kind of the super complex cases that require lots of subspecialty care, the types of things that need the depth that Mayo Clinic can offer, and a lot of HIMSS cases as well. So happy to speak today. Thank you for inviting me.
Perfect. Thanks, guys, for coming out here up to UND to come talk about this really important topic. The way Ryan and I kind of envision this panel is kind of starting out with a few basic questions, just kind of getting the ball rolling, and then taking a lot of questions really from our audience and those on Zoom. So we're really excited for you guys to be up here and to kind of demystify the process just so that everyone's understanding of what kind of goes into all these things. So thank you again for being up here. So Ryan, for anybody who's in the audience, if they have a question, Ryan, just kind of raise your hand. Ryan will come and we'll get those questions started, as well as on Zoom. We'll kind of look at my phone as we get those questions rolling in. So just kind of the first question we had is just kind of explaining the special issuance process. I know that's probably a lot more than what we think it is, but just kind of getting a general idea of how the process works for those who don't understand really how that process works. Just kind of a general overview.
Do you want to start, Mark? Dr. Christensen?
So in my position, I'm not a HIMSS AME. We do, like I say, about 1,000 collectively at our clinic. So the special issuance process often starts out with someone coming in to see us. There can be multiple different reasons for special issuance, not just the mental health issues, obviously. And oftentimes it's a matter of they come in, maybe it's their first flight physical, they have a history of a diagnosis that the FAA deems as something that needs a special issuance. And oftentimes we do our flight physical, we go through the whole process, we do what we call a deferral, stating that we're going to put it back to Oklahoma City to make the final decision. And we send in all the paperwork that we have access to if possible. Sometimes they have medical records, sometimes it's back 10, 15 years, they don't have access to that. So our process is deferring the physical, send it into Oklahoma City, and then anywhere from 2, 3, 4, 5 weeks later, a letter gets sent out to the airmen where they hopefully spell out exactly what they want them to do or what information they need to hopefully get a successful medical certificate. At that point, it's up to the airmen to return all the information that they have, and oftentimes that's where we come back in again. They get a letter and they're not quite sure what they need to do or how they can access this information, and we try and help them with that. And oftentimes that's, as Dr. Wolff alluded to, that's where you start going into some specialty areas and sometimes need some referrals to specialists in various areas that can give you the information that you need. At that point, they send in the information. Hopefully, if there's a successful review in Oklahoma City, and he can talk about that in a minute, they send out potentially a new certificate, and then oftentimes it's a yearly thing where they end up coming back anywhere from 5 to 7 years, every year annually with, for the special issuance, having some information that they need to submit every single year to make sure that they've continued to, whatever the diagnosis was, have adequate treatment and or follow-up for the condition. And oftentimes it's just a matter of bringing in your paperwork. Then at that point, I can oftentimes issue a certificate and they go on their way with their certificate on an annual basis. But you may want to talk more about the actual process once it gets sent in to Oklahoma City.
Well, I'll defer to Dan for the process, and although he's in DC. But let me just put the special issuance into perspective. There are really 4 outcomes when you take a physical. One, you can be fully qualified, and the AME can issue the certificate, and that information gets transmitted electronically to the Aeromedical Certification Division in Oklahoma City. The next level of complexity is you have a condition, but the AME has the authority to issue that certificate, and that's under a process known as the CACI, Conditions AMEs Can Issue, and there's a set protocol that any pilot can find in the Guide to Aviation Medical Examiners to know what that protocol is and what he or she needs to bring to the AME so that they can walk out of that exam with the medical certificate. There are other conditions such as that are called AME-assisted special issuances. And these are situations where they go through the special issuance process that Dr. Christensen talked about. But it is I won't say benign enough condition, but a condition that tends to be more stable and requires periodic information. And so in that situation, if the airman comes in and brings the appropriate information that's required, usually on an annual basis, then the AME can go ahead and issue the certificate, submit that information to Oklahoma City, to the Aeromedical Certification Division, get a new special issuance letter. The standard special issuance goes for about 6 years of annual reports, and those are conditions that are primarily subject to some sort of change, either deterioration in the condition or may require new medications, but the FAA wants to see information on an annual basis. There are some special issuance that require more frequent reporting, particularly in the area of mental health with substance abuse and also pilots on SSRIs. In most cases, the special issuances are granted in Oklahoma City for the medical conditions, although there are some complex medical conditions that get deferred to FAA outside consultants to review, make a recommendation to the Federal Air Surgeon, and then the Federal Air Surgeon's office makes that determination. But there are a few conditions, particularly in the mental health area, that the Aeromedical Certification Division in Oklahoma City does not have the authority to issue, and that is not delegated to, because the headquarters is the supreme judge of that. But those decisions can only be made at the Federal Air Surgeon's office, and those include pilots on SSRIs or any of those pilots in recovery from substance dependence disorders.
If I could add one, or I guess 2 points to the special issuance process. The first one concerns the initial issuance, and the second one concerns the follow-up requirements or the potential for follow-up requirements. When it comes to the initial issuance, my impression, or at least the way I tend to explain it to pilots, is that they're trying to figure out, what were the circumstances around this, and is it stable? What's the likelihood of recurrence, and what's the risk involved with your continuing to fly or you're starting to fly? And we want to be able to characterize that for the FAA and provide some estimate. Now, once we understand that, the follow-up requirements that the FAA tend to expect, in my experience, tend to be about the same as what your doctor would request regardless. I can't really think of any cases where they tend to be very different from each other. And in the few cases where I can think of some differences, I've often been able to get on the phone and we're able to kind of work some of that out so that we can get closer to some agreement. I mean, occasionally we have some differences, but they tend to be differences between different doctors' opinions, and we're able to sort some of that out. Curious your experience.
I can think of 2 instances where it may be a challenge for the airmen to get those additional evaluations that are required by the FAA, and as a result may not be covered by the airman's insurance if they have that. The classic one is a requirement for repeat cardiac catheterization after revascularization. The FAA requires a radionuclide stress test for first and second class airmen, and a repeat catheterization, and many times that repeat catheterization is not covered. The other one is within the SSRI protocol, and that's the requirement for repeat neurocognitive testing on an annual basis, and frequently that's not covered. So it does put the airman at some financial risk to maintain his or her medical certificate in those situations.
Yeah, that's a fair point. I was thinking more in terms of following up with your physician, making sure that you're checking in about these conditions.
So I want to get down to a couple basics. So I have 2 main points to tag along what they're all saying. One point has to do with kind of a method to the madness of how special issuances are processed. There's 2 variations I want to describe. And then the second main point I want to make is, well, in terms of a special issuance, where does it go? Who adjudicates, that kind of thing. The first point in terms of special issuances is in AME, I was always trying to predict what the FAA would want for the workup, right? Depending on the complexity of the problem. Now, we know certain things like SSRIs, there's a specific protocol that needs to be followed, and I would try to anticipate that and have the airmen do those things for those, and then be able to submit one package and defer it to the FAA so they could adjudicate that. What I'm seeing a lot more now, even at the FAA, than I even thought occurred when I was in AME, is the airmen themselves, the pilot themselves, and or the AME isn't aware of the specific things that is needed and goes ahead and does a flight physical, defers it, and it gets set into a queue in Oklahoma City. And then that's when an FAA physician reviews it. It could be any general FAA physician to determine what is the next step. What more information do we need? I used to call that the FAA loop. When a pilot or AME got into that and you're going back and forth with the paperwork. Now that is a way of doing it, right? Finding out what the FAA wants in a stepwise fashion. Of course, as you can see, that would take much, much longer to do it that way. So it brings me a little bit to my second point that I want to make about this question about special issuances. On the SSRI side, the Federal Air Surgeon, when it first was created, the SSRI Protocol, it was reserved to be adjudicated at headquarters. So, but all the documents, all the workup still goes to Oklahoma City. It still gets scanned in. We're in the process of doing a beta testing for alcohol and drug to have the AME scan and upload those documents. But somebody, an actual person, still has to scan those documents into our system and then triggers another analyst up at headquarters for somebody like myself. So a psychiatrist actually reviews the SSRI cases. Now, alcohol and drug, if it's strictly just alcohol and drug, those are through Oklahoma City, through a couple of specific FAA physicians there. So just a little window into that. Might generate some more questions.
And also, if I can mention, the FAA has done a remarkably good job of updating the Guide to Aviation Medical Examiners. And in most cases, an airman is free to search that guide and find the specifics that might be required, the information that's required. And the FAA also has recently published a protocol for what's considered a current status report or a physician update report. And if the airman is successful in negotiating with his or her treating physician, much of that information can be provided initially to the AME and substantially shorten the timeline for making the decision, because it doesn't have to go back, go into the queue, as you said, get reviewed. Instead, you're bypassing that step where the FAA will send a letter saying this is what we need. You've anticipated that because you've looked at the Guide to Aviation Medical Examiners and worked with your physician to get the appropriate information to submit that early. And that reduces the workload in the FAA because that's one less time they have to touch that paperwork.
Cool, thanks so much. So talking through that process, how long does like a typical special issuance take? I know there's not probably a standard answer, but is there, like what's the goal and kind of how long is it taking right now?
Wide variance. I don't know if there's a set amount of time. My observation prior to working for the FAA, what we were told as AMEs, generally speaking, was that first class had priority over second class, had priority over third class. There's a lot of variables that go into that even adversely affect that, and even that's not, as I can see now on the FAA side, the type of system that we use doesn't put in a diagnosis the way we would like it to, so it's hard to track. We don't even have ways to track that number very well in terms of which cases get adjudicated when, because like what Dr. Quay was saying, that something goes back in the queue, it starts a timer over. So we're trying to do a new method so that we don't have to go back in the queue in that way. You can just contact that same FAA physician that reviewed it, put it directly in that FAA physician's work box, basically, so that shortens being in the queue yet another period of time. Basic answer to your question is it could be anywhere from a few weeks to, I've seen, even as an AME myself, waiting on a special issuance 2 years, 24 months. This was back when we had some of the government shutdowns before the pandemic that slowed things down. But it's a wide variance. Don't have a good answer for you.
Perfect, thank you. Okay, so one of the questions we also had before we kind of roll into questions submitted by the audience is, what's the process, for example, of like a college student here at UND or another flying school that maybe was diagnosed with something that now requires a special issuance? How do they go about doing that while still trying to maintain their flying privileges? Is there a way to do that? How do they go about that process?
I would say first and foremost, you guys jump in, start a conversation with your AME ASAP. You guys.
Yeah.
Yeah, it obviously depends on what the cause is. If it's so we've had situations where airmen will come in and they will be getting their first flight physical. They maybe have something they're concerned about and possibly don't say anything about it to us. They don't document it on the MedExpress or tell it to us. And then for whatever reason, they may have some guilt or some other thing comes up where they think, well, gosh, I really should report this. And then oftentimes that's where I will let them know that they need to contact Oklahoma City and let them know what it is. And obviously it depends on how serious that is. It can be something as benign as, I had an incident where I fainted when I was in second grade or something like that. Or it can be something more serious, like I have ADHD and I didn't disclose that on my MedExpress, and I think I need to do that now. In those situations, contacting Oklahoma City, they will, like we talked about, they will let you know what they need for further follow-up potentially, and the special issuance can get started at that point. Again, depending on how serious that is, they would have technically flight privileges until they get the documentation or a final answer from Oklahoma City, but oftentimes that just kind of depends on the severity of what the situation was.
We always encourage the airmen to report everything on their special, I'm sorry, on their medical express application. Falsification of an application is a bad thing, and subject to penalties if someone intentionally falsifies. And those penalties could be revocation of all certificates and ratings on the pilot side, but also revocation of the medical certificate too. So always be honest, engage in the conversation with the AME very early in the process. Look at the Guide to Aviation Medical Examiners for information about what you need, and lead turn that by as much as you can so that you're not in a situation where perhaps you would meet the qualifications, but you don't have the appropriate documentation. You're perfectly healthy, but you're not eligible for a medical certificate until it goes through that review process.
Other thing I would add too is starting a conversation early on with your, if it's a therapist, primary care doctor, anybody you've seen, even if you're not sure if you have a diagnosis, make sure they know that you're a student pilot, you're a pilot, you know, that this is something that's your occupation or your interest. It helps them to better provide the care that we like to see in the review of the record, right? In terms of helping to adjudicate things that are reported on the 8500, the MedExpress, et cetera.
In my experience, and I can't speak for all of my pilots, many of them have been more fearful that things are disqualifying than things actually are. And I can't tell you how many people have come into me absolutely convinced that this is going to end their career, and then we have a conversation. I say, oh, that's not a big deal at all. Or, you know, it's just de-escalating having a conversation. So I really reinforce, you know, being proactive, discuss it with your flight surgeon, have that conversation early, be open, and I think that that's something that, frankly, I liked in the military, is that we had more regular contact throughout the year, and is a beneficial relationship, and I try to impart that upon my patients. Is just call. You know, if you have questions, just, you know, shoot me a note, call, let's talk about it. And sometimes these don't even turn into visits, you know, but it's better to have those questions when they come up, or if somebody wants to prescribe you a medication, or you think this diagnosis is, you know, whatever, or you want to see mental health, like let's just have a quick conversation about it, because it's much easier to do it then than, you know, 2 years down the road.
I would also add on to that it's a lot easier to certify somebody, whether it's unrestricted or a special issuance, when we can see that they've sought care early on, and the risk's much lower. But when we can tell that something's been smoldering or just gotten much worse when it could have been adequately, you know, treated earlier on, and now there's a lot more treatment involved. Those are much harder to certify in a way that we can look at the risk without maybe sending them back to specific treatments. So,
or we've probably all dealt with revocations when it's really nothing, but it's just an unknown at that point to the FAA.
The other thing I would encourage all the students out here early in your career is to establish a relationship with a AME who is very proficient, and through establishing that relationship, that person will get to know you. You can have that open conversation, similar to the experience we had as military flight surgeons. That conversation goes on, and that AME, if they know you well, is willing to call up the Air Medical Certification Division, as Dr. Christensen does quite frequently here, with the credibility with the FAA that they're doing a good assessment. And most of the time, the folks at the Air Medical Certification will defer to the judgment of the AME and allow the AME to issue the certificate. But if you seek going to an AME like some pilots do, who don't do an exam, we call them MIC AME. You go to door 1 and order a first-class medical certificate with fries, and door 2, you pick up your certificate. Those aren't the AMEs that are going to call the FAA on your behalf, because they don't know you. They don't have the credibility with the FAA. So I strongly encourage all of the students out here to establish a long-term relationship with a very good AME so that you can maintain your medical certificate when things arise, because things are going to arise in your career.
One certainty in life is, as you get older, you will have things on your medical.
One quick question here for you all out from the audience. What's the FAA's line on this punitive piece? We encourage our students to get a medical early on in the process, in a lot of cases well before they understand the implications of disclosing or not disclosing on a medical, or what they need to disclose. And I know there's been a few situations where that it's over time they've realized now that they're maybe they're in a collegiate aviation situation, and they understand what something that they maybe should have disclosed on their medical. Is that going to be something that they're going to face a punitive response from the FAA, and really the first time you get a medical, or even the second time you get a medical, and not being familiar with the question, or with the questions that are being asked?
I would say most of the time, no. The FAA does not go after most pilots. I mean, it has to be pretty. I mean, just being at the FAA now just under a year, it has to be a pretty egregious example of what I would call intentional falsification, and that actually there is a legal standard behind that. But I would have to see a pattern in the record of multiple 8500s that individuals not disclosing it, and then have evidence from their clinical record that they're intentionally hiding that, like discussions with the therapist or a doctor, et cetera. And even those cases, I'll refer to that. I don't do those investigations. I'll refer those to an FAA lawyer, and they'll say whether it's something that they want to. That's what I understand you mean punitive, where they'll actually go after them legally, and even then it's still a full investigation. They still can appeal that, et cetera.
If I can follow on question. So how about a lot of kids today are being diagnosed with things, or even our college students today that were diagnosed with something 15 or 20 years ago, that when it's diagnosed that way, that is a disqualifying issue. So, but under the current terminology and things like that, it would be diagnosed differently today. So a student comes in and says, have you ever been diagnosed with a mental health condition? Yes, it's in my medical records. Obviously they want to admit it, but under today's rules, it wouldn't be.
So I'll answer that question, but let me address the first gentleman's question. It's always better to self-disclose than to have something discovered by the FAA that you haven't disclosed before. So the opportunity to self-disclose usually is looked at more favorably than something that was intentionally concealed. With respect to your question, the FAA has protocols to look at, and particularly in the mental health world, and Dr. Danzig can talk more about this, but if there was an inappropriate diagnosis, there are a number of HIM psychiatrists, HIM-trained psychiatrists who are familiar with the FAA medical standards, and they might get an evaluation from one of those psychiatrists in a forensic sense, and they look back retrospectively. Did the person actually meet the criteria for that diagnosis? In many cases they didn't, but they were treated. We're family physicians. All four of us are family physicians, and I don't mean to downplay the role of family physicians, because they do a great job, but sometimes it's easier to prescribe a medicine quickly and make a diagnosis and not take the time to really ascertain whether someone meets those criteria. And that's where a retrospective look by a psychiatrist to say the person really didn't meet those criteria and really should be qualified according to the current FAA policy would be useful. But many times it does require that forensic evaluation retrospectively.
And I think we're all very aware of that phenomenon. And in my experience, the FAA is very aware of that phenomenon. We're seeing a lot of people on medications like that or diagnoses like that. And when I call the FAA, they're very aware and happy to understand, deal with those cases appropriately. In my experience, they're not trying to stick a ton of people with unnecessary special issuances. And really, it's just we're trying to sort out who actually needs following versus who was on, medication for a little while and unnecessarily. But it does require some workup, and Dr. Christensen's been fantastic about those. I do get calls from you occasionally about, hey, can you take a look at this, or may need some workup, and we kind of sort out who needs a little bit more workup and who we can handle it on.
And to tag along that, I mean, what we're describing is something, it's a dynamic seen outside of aviation medicine, certainly. I mean, we're all familiar as clinical practitioners to look at a medical record, and we understand that overdiagnoses happen, misdiagnoses happen. Much of that dynamic is actually mediated by insurance and billing motivation, for lack of a better word, right? We have to get paid for the work. The hospital looks more critically at our documentation and billing codes than it does to sometimes the quality of the care. So we get that, we understand that. We're always looking at what I call the narrative, the story that the AME and that the pilot provides. And we're trying to marry that up to what the actual clinical record says or does not say, or what it should say, or maybe what it overstated. So I'm always looking very closely at what actual symptoms are documented. Does the story even make sense for this diagnosis? Because we understand things can be way overdiagnosed. It's a common practice in mental health, especially for therapists, to be able to get paid, to put down some type of code so they can get paid, and a V code insurance may not pay, right? We understand that. So we definitely want to take that into account because we don't want it to hurt the pilot in their endeavors. And family practice docs, primary care docs, mental health, we all know that. We all get that.
About the retroactive evaluation. So say you're a college student, you've just submitted for a medical process, you're trying to get your private pilot license. At what point, like who would you recommend going to get like a retroactive evaluation versus going for an SI if as a kid you're diagnosed with ADHD or some other limiting condition?
I'd start with Dr. Christensen. I mean, I think that's...
We have some specialists, and we're going to talk about this a little bit later. We're trying to get some more in this area that can help out, and locally even. We have a good relationship with some doctors in Minneapolis that have done evaluations. The FAA does have specific criteria for the testing that they require. The classic case is, like we've alluded to, is people who possibly just were treated with Adderall when they were in second grade because it sounded like they had ADHD. They weren't formally tested. Given that history, they would most likely want the neurocognitive testing to rule out the diagnosis. Oftentimes they require a urine test to make sure a drug screen before you do the testing. But they have specific criteria set out. We have a lot of providers that we've used in the past that are familiar with the ways of the FAA, and we can get a referral to them and get that taken care of.
I would concur. We just start with the AME. That's the best place to understand before you go to spend money on an evaluation. To add a little bit specific about ADHD, because we know about the rates of prescribed stimulants and diagnosis. Our chief neuropsychologist is right now in the process of putting together a new policy that may eradicate the one size fits all. Everybody needs testing just because they were on 5 months of a prescription stimulant way back 10 years ago kind of thing, right? The military's already gotten a little past that part and come up with some waiver type policies. And so we're in the process of doing that so that people don't have to spend inordinate amounts of money just to get evaluations that they may or may not need. So.
Perfect, thank you. So one of the questions that we had come in on the Q&A was talking about like the differences in information, like where can somebody find the correct information instead of maybe one person told them this, one AME told them that, they found this online. Like, where's the best place to get the correct information to kind of work through that process?
Well, I'd start with the AME guide. It's freely available to everyone. Sometimes it's a little difficult to search, but they do have a search the AME guide function in there. You can type in a keyword and get access to the decision-making protocols and the FAA policies. And also, as I said, talk with a trusted AME who does a lot of these so that you can get the appropriate information before going down a rabbit hole, spending a lot of money for something that may not be necessary or might not be the information that the FAA wants.
So the AME guide is updated, I believe, every 3 months, 4 months.
Monthly.
Monthly.
On the last Wednesday of the month.
I only get the updates as an employee every 3 months, so it's quarterly. But if you can actually download the PDF and search it, that's what I was going to add to that as well. It is updated periodically. The other thing I would say, if you can't find an AME guide, which is possible, it doesn't have everything in there, then definitely talk to an AME. Otherwise, just call the FAA. We have FAA physicians both at Oklahoma City and headquarters. I freely give my email and phone number out if you have a question about something you're not sure. You can't find the AME to give you, or you're getting discrepant answers from different AMEs, which I've seen that happen. Definitely reach out. You know, the answers are out there.
So looking at that AME guide, is there any process to kind of make it simpler for somebody who might not be well versed in, you know, the policies of the FAA or the processes of the FAA? Is there any way to make that more streamlined for, like, let's say a student pilot who's trying to, you know, go for their first medical, might have had something in their past like we've kind of talked about all day today? Is there anything to kind of like help streamline that process?
You know, go ahead. I usually tell at a first flight physical, I give a little bit of an overview, and I'm not sure how best to describe that, but I think I kind of consider it like, I mean, you should know how to find the FAR, and you should know the pubs for the aircraft. Like, you should spend a little time on the FAA website and find the master document of the AME guide, which is it's like 563 pages. They update it once a month. You'll see the update dates. I personally don't recommend downloading it because they update it so frequently. I don't. I pull it up every single day in my office, and I just Control F my way through it. And you'll see these summary tables of the major diseases. And if you know that you have some medical issues, like, search for them and see if there's stuff in there, and just generally be aware, you know, and then be able to have a conversation with your AME. And if you're going in for your first flight physical, it might be worth, you know, calling and say, hey, can I have a consult before the first flight physical, and just talk about these medical issues. I also, and actually to the question that was raised earlier about, you know, do I need to report it? I try at the first physical to have some of those conversations, not to scare anybody, but like, I just make sure we kind of talk through it is a higher level of expectation. You know, there's a lot of responsibility to hold a pilot's license, both for the aircraft as well as in your own reporting, as well as in the medications you can take, even when you're not flying. And so I try to make sure we have a little bit of a conversation about that from the human factors perspective. And I think that's sort of all part of this package that we're talking about, and you know, kind of comes with the job, unfortunately.
I would echo what Dr. Wolff just said. You can get the information from the AME guide. I don't download it either. I just search it each time. But if you haven't taken a physical yet, you can get that and speak with your family physician about what might be required. But also, particularly what he said, give an AME a call before you take the physical, before you fill out the MedExpress, and say, I'm interested in that. And if the AME says, no, I don't want to do that, you probably want to get a different AME.
Completely agree. Yeah.
Yeah, like for UND students, Dr. Morgan, Dr. Heinley, and myself, if they have any questions, they can make an appointment to see one of us and talk to it. That happens almost every week. We have someone who will either phone call or make an appointment, and we can go over. Like they said, you can print off everything that we know. It's available on the internet. Sometimes they'll bring in a specific sheet and say, I have a question about this, and that's perfectly fine. But for UND students, or even if you're not, we do flight physicals for people who have graduated and moved on and not UND students. They can call, which happens all the time as well. So they can just give us a phone call or make an appointment, and we can try and figure it out.
Perfect. And to talk a little bit more about that consultation that you guys recommended, is that something that is then also reported to the FAA, or is that kind of before the process started, so not kind of part of that process when they fill out that MedExpress form?
Most of the time, if they just have a specific question about potentially a diagnosis they have or something, we don't even need to document that as a visit. Technically, you're supposed to write down every healthcare visit for the previous 3 years. If it's something similar to that, it's not going to be a big issue at all.
Perfect, thank you. So moving into some more questions that we got from the audience. One of the questions was about like a DUI or a minor in possession. So let's say somebody got a minor in possession or a minor in consumption or a DUI, but maybe don't have a history of substance use or a substance use disorder. How does that kind of work with a medical?
I think I can do that, me. That's my life. So the FAA has specific criteria that you can go into and be issued a medical certificate, or the AME is required to deny the medical certificate. Generally, a second DUI in a lifetime, or a second alcohol-related motor vehicle infraction, a breath alcohol or blood alcohol concentration 0.15 or greater, or this is one that gets a lot of folks, is a refusal to test. If you refuse a roadside breath test or sobriety test, that's grounds for the AME being required to defer that certificate. If that certificate gets deferred, then there's a letter to the airman that comes out, or the AME can tell the individual that they will need to get an evaluation by a HIMSS-trained psychologist, neuropsychologist, or psychiatrist to determine if there's an underlying problem. In many cases, it'll be determined that it's a one-time stupid event, okay? And no harm, no foul, but you get a little letter of warning from the FAA, don't do this again, but you're qualified. The second tier is, we're not sure if you have a problem or not. Maybe you do, maybe you don't, and that airman might have to go to a HIMSS AME, although not be in the HIMSS program, under a process called monitored abstinence. And in that situation, after the evaluation determines that the individual probably doesn't have an issue with the substance use disorder, but they need to demonstrate for at least 2 years that they will not drink or partake of the substance. So they're required to get a minimum of 14 no-notice tests during the year to determine that they can remain abstinent. And if they go through that period, usually 2, possibly 3 years, then they're released with a standard medical certificate rather than the special issues they had, with a warning that the next event may trigger something. And if someone goes through an evaluation and is determined to have a substance use disorder, then they need to go through the protocol that the FAA requires for the HIMSS program. And there are different sorts of protocols depending on whether you fly for a carrier that has a HIMSS program, whether you're a first-class airman, or whether you hold a third-class certificate. And the level of monitoring varies substantially with that, with less monitoring at the third class, less rigorous monitoring, but still good monitoring at the third class, and very rigorous monitoring for at least 8 years at the first class level. And Dan processes a lot of those that we submit.
Yeah, I mean, you stated it very well. The only thing I would add is by the time some of these cases get to my level, they're already appealing to the federal air surgeon, or it's a first class. Those come to headquarters as well, and it's just sorting out, is this really substance dependence or substance abuse, or something that still can be cleared or requires monitored abstinence, 2 years.
And also let me point out that the FARs in 67, 107, 207, 307 are the mental health areas, and they use the diagnosis substance dependence and their specific criteria, 4 specific criteria, and substance abuse. If you go to a psychiatrist now, those terms are not used anymore. They talk about substance use disorder, mild, moderate, and severe. So that's why it's very important to go to someone who's had HIMSS training so that they can put it not only in the clinical context of substance use disorder, but they can also apply the FARs to determine if someone meets the qualification criteria or is disqualified according to the FARs.
Yeah, but and again, at the end of the day, it's about safety. I mean, we want you to be able to walk away from the aircraft safely. So, I mean, all the diagnoses aside, it's about, report it. It's just being proactive about it. And I guess that's, if I'm understanding your question at the beginning, I mean, having the conversation up front, was that sort of what you were asking on that?
Yeah, that's one of them. And just to tag on to the point of, let's say that somebody does go and see somebody who might not have HIMSS training, right? Maybe they didn't know that, hey, I should have seen someone who had HIMSS training, or maybe there was a financial or a travel burden, right? How does that kind of, let's say that they did use that kind of terminology that is not used in the FARs or is not easily translatable, how does that work if maybe they did do that?
So, The list of HIMSS-trained psychologists and psychiatrists is not available to the public, but it is available through HIMSS AMEs. And I would not waste my time for a second, my time or money, going to someone who isn't HIMSS trained, because essentially you're going to have to repeat that evaluation. So I think that would be the best way to contact a HIMSS AME to get the appropriate evaluation. But let me just go off topic for a second. Over the course of the HIMSS, which has been in place for 49 years, we have over 10,000 airmen who have been certified with a diagnosis of substance dependence through that process. Currently, depending on what numbers you look at, there are probably about 4,000 airmen in monitoring for this in the HIMSS program. And I must say my experience with those folks with a successful recovery and are being monitored are these people are wonderful people with a terrible disease who, after they have completed treatment, are filled with humility, with gratitude, are absolutely hardworking. And many of the people in our senior leadership positions within the airlines and the aviation industry are quote unquote graduates of the HIMSS program because of the change in their lives. So it's been perhaps the most challenging part of my professional career, but far and away the most rewarding as well.
I have a couple of alibis. So that P&P list to the psychiatry and HIMSS, that actually is the one that's updated every 3 months. But I learned last month that we had an aviation psychology seminar for our HIMSS neuropsychologists last month. And I actually I discovered there is a copy of the P&P list out there. You could Google it. Right now you could find it. It's approximately dated about a year ago. But you're correct in saying we don't publish it, but one got out there, and you could find it. But the HIMSS AME list is on the internet, from what I understand.
Yeah, I have a question here. I have the microphone. My name's Erica Hidinga. I'm with United. I just had a question playing off of this conversation, actually. The HIMSS program, I can say personally, as a pilot, is so well respected. Pilots appreciate that program very, very much. I was wondering, do you see in the future maybe some kind of HIMSS type of program for any kind of mental illness, like maybe depression recovery or anything like that?
We've actually had some discussion about that this past couple months. There's a background history on how the SSRI protocol came about that I discovered since working for the FAA. They modeled that protocol, the SSRI protocol, on the HIMSS protocol. And the main reason at the time was simplicity, administrative effort, right? There isn't anything unique about a HIMSS AME seeing somebody who's on an SSRI necessarily. It was the fact that a HIMSS AME knew the administrative burden it took to put that special issuance package together. That's the history. Correct me unless you recall anything different. You were there at the time, but that's what was going on in 2010 when we authorized those 4 SSRIs. Well, we're also realizing, because every time I go to an AME refresher to teach these classes, I'm always trying to recruit people that are interested to become HIMSS AMEs, but we're always getting, just from AMEs in general, not just HIMSS AMEs, how do we get more people interested in becoming AMEs? It's something we're trying to figure out how to recruit more individuals. Does it have to be a HIMSS AME necessarily that sees somebody with depression, right? All AMEs, as you guys have all said, are supposed to know how to do special issuances. We train them on that at the refresher courses, and they should know that. So I don't have a good answer for your question, but I would almost counter it by saying, shouldn't any AME be able to see a pilot with depression, right? And handle those special issuances? Otherwise, we're cutting, right now we have an access to care problem with HIMSS AMEs, is what I'm saying. It's not just for depression, but anxiety.
Yeah, I guess I'm talking more specifically just the HIMSS program itself. It allows pilots to leave for a significant amount of time, really, and save their job. And they can come back and still highly respected. They share the fact that they're in the HIMSS program, and they're monitored for the rest of their career, really. So I was wondering if that could be a program eventually for mental health issues.
Erica, if I can expand on your question there, and I think one of the components of the HIMSS program that has been so successful is the monitoring, particularly by peers and supervisors as well. And perhaps adding that as opposed to going through the neuropsychiatric evaluations. I'm not going to speak for Dan on this one.
So to help me understand what you're describing, are you talking about incorporating certain aspects of the current HIMSS program to apply to other types of disorders, like depression?
Like maybe the way that HIMSS is respected by the pilot community, I guess, and we know that pilots are getting treatment for some kind of addiction. I was just curious if you could see that happening in the future with some kind of mental health, like somebody's on an SSRI and maybe they're able to get back into the flying community and have some kind of protocol to get them back into flying, if that's possible.
I mean, we're looking to at least expand the SSRI program to include other antidepressants for one. We're already in the works of doing that, but special issuances under the SSRI program right now require an individual to see the same HIMSS AME throughout their special issuance. Yeah, and a HIMSS psychiatrist. It can be a community psychiatrist too, depending on the class of medical.
Dr. Trotter.
I think I could probably speak loud enough. No? It can be loud. Testing? All right. My question is, it was brought up in your answer to limited access to HIMSS AMEs. One of the things that I've gotten mixed messages about is the HIMSS neuropsychology versus psychology. I heard Dr. Snyder say that HIMSS psychologist, neuropsychologist, or psychiatrist. However, when I had asked earlier, there was a requirement to be a neuropsychologist to be HIMSS certified. So I'd love some clarification whether or not HIMSS requires neuropsychology versus psychology, and then again, expanding the HIMSS process to psychologies, especially for rule-outs like ADHD, depression, anxiety, would help that access, or in my mind, probably alleviate some of that access to that HIMSS neuropsychology.
So, through the HIMSS training process, we educate psychiatrists, neuropsychologists, and psychologists. Okay, neuropsychologists can do the neurocognitive testing. What I was referring to earlier was getting an evaluation if you had a minor under possession or DUI. That can be done by any of those three. To enter the HIMSS process, though, with a diagnosis of substance abuse or dependence or substance use disorder, that requires a neurocognitive evaluation, which can only be done by a neuropsychologist, not a psychologist. Okay? But any of those three, psychologist, neuropsychologist, or psychiatrist, can evaluate the pilot under SSRI protocols, too, as well as what Dr. Danzig said, your local psychiatrist could also do that, providing the appropriate information. Does that answer your question?
Yes, so it sounds like if we're struggling with substance use or ADHD, that is requiring a neuropsychologist at this point. But for depression and anxiety, there is a process for psychologists to become HIMSS certified?
Yes. Absolutely. This year we trained a combination of AME psychologists and psychiatrists. In the initial training, we trained about 200. So it was about a 50-50 mix between AMEs and mental health professionals.
Not to complicate things, but air traffic controllers will see psychologists. So I don't think that was towards your question, though.
Air traffic controllers will see for
When
ADHD or just?
Just to become air traffic controllers, we will actually use psychologists to assess them with personality testing when they're for onboarding for employees. So not to complicate that. I didn't know if that was part of your question.
Extra information, I love it, thank you.
Cool, thank you so much for all that. So we have a few questions going back to, we talked about the electronic scanning into the FAA system. Is there any plans to do that also for mental health issues, or is that solely going to be on that drug and alcohol dependence side?
Right now we're doing it for first class. HIMSS AMEs can upload it through, we call it Huddle. So it's already being done, and that's kind of the beta test that's working. Now we're just trying to expand it to all, not just mental health, but anything that AME could send up to the FAA.
Gotcha. Cool. So that should kind of help alleviate the process and that time constraint we talked about earlier.
We hope.
We hope. Okay. So another question we had about that MedExpress form was the requirement to repeat any like diagnosis you have on any other medical. So let's say, that first medical you got as, a student pilot, you have to, let's say you're diagnosed with depression back in elementary school, back in middle school, right? And then the requirement to repeat on each following medical and how that can kind of create some issues of going back and like tracking medical records from, 10, 15 years ago. Can you kind of speak on why that requirement is there and kind of the burden it might put on somebody to find those records?
You don't necessarily need to find those records every year. So if it's previously been reported to the FAA, I would ask that you check the box yes and just answer that it's been previously reported to the FAA.
You're talking about question 18 on the MedExpress.
Yes.
And what it says right at the beginning, have you ever in your life been diagnosed, or do you currently have? So if you've checked,
now, or have you ever had?
have you ever had, paraphrasing somewhat, but basically if you've checked yes to a block in the past, you need to check yes to the block on all your subsequent physicals. And as Dr. Wolff said, you can put previously reported no change. If you go to a new AME, the new AME may ask for information about that. And that's another benefit of establishing a long-term relationship with an AME. And then the second block, which presents some problems to pilots or anyone going for airman certification, is block 19. It says report all visits to healthcare providers in the last 3 years. And it's best to keep a list of those, but if you've already reported it, you can say those visits are previously reported, but any new encounters other than FAA physicals and routine eye and dental visits are required to be reported.
What I would add too is, as a pilot, you're entitled to the finalized copy of the MedExpress once the AME signs it. That's how I actually use that to help me remember in the future which ones to say yes to, and then I eventually, remember it every single time. But as a private pilot, I don't have to go in that often, so I forget, right? But even every 6 months, once you get older, like Dr. Wolff was talking, you might have medical issues. Which blocks did you say yes to, right? We understand people get confused, and we don't hold that against them, but what I would encourage you is ask your AME for a finalized copy, and if for some reason you can't get hold of them or they retired, et cetera, just contact the FAA, you can get a finalized copy of it as well.
And also, when you click submit too, you have the opportunity to print out a copy right there. Now, that's not the AME finalized copy, but it's a record of all the work that you've done, and you've inputted into the MedExpress application.
Actually, per the last training I did, we are not allowed to provide that copy, but you're entitled to request it from the FAA. But
as Amy, I was giving them a copy. Maybe I shouldn't.
But yes, excellent.
So kind of for somebody who might be going in for another medical and they might not be a little confused, but might not fully remember everything that they put on the last one, kind of requesting that medical that was already processed would be a good way to kind of help as a starting point, so you're not doing those hours of work again, is kind of what we're hearing.
Right.
Correct.
Yeah,
And on top of that, every subsequent time, you just have to put yes, and then as on your MedExpress, you can actually put the acronym PRNC as the pilot you're authorized to do. The AME still has to write in some comment on it, but that's on their end. But you don't have to describe the whole thing over again. If you're seeing a new AME, you may have to describe it to them so they understand what the history is. But
yeah, just like you keep a copy of every knowledge test that you take or every 8710 you filled out so that it has all your hours and you're applying for that, keep a copy of every medical application that you make so you don't have to go back and do that work. I mean, I'm a pilot examiner, so I have to take a check ride with the FAA each year, and I have to fill out all the hours. It's a pain in the butt to go back there if I've lost the last one, so I keep all the 8710s. So I don't have to do that work except for what I've done since the last check ride I've taken.
I was given the advice when I started in the Navy and started doing flight physicals with them, and I give this advice on first-time flight physicals. Get yourself like a 5-inch 3-ring binder. And I started one when I got my first flight physical in the Navy, and put your first physical when you fill it out in MedExpress in there, and every, you know, if you have to go see a specialist, if you send anything to the FAA, just keep putting it behind there. And it's going to look ridiculous at first, but I guarantee you that down the road, you're going to have it all there and you'll have your complete FAA record. And just, you know, if you have to move, hand carry that thing. Like, don't lose that. And it comes in handy, believe it or not.
Yeah, I'm on my third 3-inch binder, 3-ring binder with all that documentation, but it's great advice because it saves you a ton of work.
Cool, thank you. Is there, so on that MedExpress website, like online, is there any way to pull that record from there, or do you have to request that with the FAA?
To my knowledge, you'd have to request it, from the FAA,
Yeah,
which is not that difficult.
I actually haven't saved the finalized MedExpress. I just save when I fill it out. I save that copy, just so I know what I filled in last time.
The MedExpress is its own server. So once you fill it out, you can download a copy, but no one else can download. We can't touch that at the FAA. The only way that that's accessed is by that confirmation number that you give to the AME. So the AME can't access it unless they have that confirmation number. But it goes away after 60 days. So it disappears, and you'd have to do MedExpress again if it's not pulled.
The other thing is, depending what type of apparatus you're on, you can just take a screenshot or take a picture of it, and you can just save that and use that for the next time when you come in.
Yeah. I'm more concerned about what I send them, that I've retained copies of that personally.
Cool, thank you. So we had a question come in about kind of the stigma to seek treatment, right? So if, for instance, you know, as an analogy, right, let someone say someone broke their arm and they might have a stigma of seeing someone because it might get reported to the FAA. Is there any, where do you see that stigma being? Is there any way that we can kind of reduce that so that people who do need help can go see somebody without kind of that fear of, you know, the big scary FAA is going to come and take my medical?
I mean, from both as a psychiatrist and as a military and civilian flight surgeon previously, like, we call preventative health, right? Would you wait until your aircraft is starting to have an issue and not take it to the mechanic, and when it starts to get worse? We now try and take care of it early on. Now that gets to the heart of stigma and mental health to begin with, seeking help and the shame associated with it. But this is, as Dr. Wolff was describing before, in the military, it's been a very forefront, going to see your flight surgeon, trying to get on top of an issue right away. That's what we're trying to encourage with pilots in general, even the civilian side, and then navigating, you know, these disparate healthcare systems. How does the company look upon you when now you've sought some type of help, and what shame might be associated with that? So I would just say, as early as on, just getting the treatment that you can. If you're not sure what it is, speaking to somebody that it could be a close family friend, a pastor, minister, AME, taking that all in and seeing if the next step is to see a therapist, et cetera.
I'd say, sorry.
I was going to say, like this afternoon, we're going to be talking about the peer program, and I think that's a perfect example of a way to destigmatize that, in that you can start reaching out to your friends, your cohorts, in a very hopefully non-threatening environment, and we'll be talking a lot more about that this afternoon. But just make it, as soon as you feel any need to talk to someone, you know, reach out and talk to them, and make sure that it's in a non-threatening environment, and whether it's going to talk to a roommate, a classmate, a cohort, the peer program, I mean, just starting as soon as possible to address the issues is the best way.
I mean, I say that I'm in the business of performance improvement. I mean, we want you to be operating at the peak level possible, and that's really the goal here. And every pro sports team, every Olympic team, all the college teams have doctors and psychologists on staff, and that's because we've learned that teams perform better. And I hope that you want to be doing the same in whatever your job is. And that should really be the goal, and why should we not apply this to the aerospace community? So if we can get you there by seeing a counselor, by getting on medication, let's do it, because you should be doing that. And by the same token, and this is an analogy I use for orthopedic injuries, and you were asking about a broken arm. I mean, if you can't, you know, for our military pilots, if you couldn't work the risers of your parachute because your shoulder's hurting, or you can't egress from a burning aircraft or help other occupants, you should be concerned about that. You know, who cares what the FAA, you know, thinks about that? And so I think the same is true when it comes to the mental health side. So let's, you know, put on your own oxygen mask first, you know, so to speak.
Hi, okay, I have a question. So kind of circling back to the ones about substance use. So I work at the counseling center. I'm one of the addiction counselors there. And I have had quite a few aviation students. And so basically I want to make sure I'm not adding another step for them if they need to go elsewhere instead of coming to see us first for an alcohol and drug evaluation. And also then to just kind of get some clarification on time that they might be away from flying. So I will have a student come in who has maybe been charged with a DUI, who is waiting to say anything to the FAA because they have an attorney and are hoping to get it either off their record or kind of drop down to maybe reckless driving. So if there's not a diagnosis of a substance use disorder, is there a certain amount of time? I'll have certain students come in and say, okay, I'm on a 6-month flight hold for like a minor in consumption or minor in possession. Is there a certain amount of time that a student is on a flight hold, and is that from the FAA or is that from the university? And also, should they even be coming to us at all, or should we, the second they call and say, hi, I'm an aviation student, I got charged with a DUI, should we just say, immediately talk to your AME and get connected, don't come to us for an eval?
So
I hope that makes sense.
I had this call this week, actually.
Okay, go for it.
I say call your AME right away. And what I usually do, and I did this just within the last 5 days or so, I did an addiction evaluation right away, report to the FAA immediately. We're still waiting on legal adjudication. It's all going to be visible to the FAA, even if it gets knocked down in charges. And so let's get you into treatment as quickly as we can. We sort of know what you're going to need. Be proactive in addressing it. And again, you're going to need to be abstinent. We're going to need to treat you if you need treatment, and then deal with the legal issue separately. And then when you come through treatment, then we'll start talking about getting you back up with your neurocognitive testing and HIM psychiatry.
Yeah, a couple additions to that. What Dr. Wolff described was someone who does meet the FAA criteria for substance dependence or substance abuse. But the work you're doing in the counseling center is great, and there may be pilots or student pilots, prospective pilots, who have an alcohol-related offense that may need appropriate counseling. The only ones that absolutely require evaluations by HIMS-trained psychologists or psychiatrists are those that either have refused to take a test, those that have a blood alcohol or breath alcohol concentration 0.15 or greater, or those who have a second alcohol-related motor vehicle infraction. Now, we always hear about the pilots who are trying to get the attorneys to adjust it down, but that doesn't help at all. The FAA doesn't care about the legal outcome. They care about the medical issues there. And even if it is downgraded, that's still a reportable event under 6115, FAR 6115. And there may be a second reporting requirement if there's a subsequent conviction. But any administrative action that would ground the pilot, or they get a temporary driver's license, or there's a temporary limitation on their driving privileges, that requires a report to the FAA within 30 days.
Okay. Okay, I just want to make sure I'm not adding another step, because we can get students in within a week, week and a half for an alcohol and drug evaluation. We have sent stuff to the FAA stating, this student, here's our full evaluation, no diagnosis of a substance use disorder. And then, so I feel like they want to get in sooner than later to kind of start that process. But I just want to make sure we're not having a student, I'm not encouraging a student to get an alcohol and drug evaluation done with me, paying $150, when they could bypass that and just get scheduled with the appropriate individual, basically.
I think starting with the AME makes sense, but I think it's probably going to end up with an alcohol and drug evaluation as well. And you're probably the right source for it. I don't know the other resources here, but
Yeah, $150 is really inexpensive,
Yeah, that
because
sounds fantastic.
these FAA evaluations are $2,000 to $5,000.
And 1 week to
So,
get in sounds fantastic too.
And again, if it's early in someone's career and it's a relatively minor incidence, Your evaluation may be perfectly appropriate. What I was talking about is those that cross the threshold where the AME does not have the authority to issue a certificate and is required to defer.
Thank you for the clarification.
Perfect, thank you so much. And then we got another question from the Q&A that talked about the requirements to report, let's say that someone is seeing a therapist or a counselor for just kind of like their own wellness, right? It's maybe something went on at home, something is going on in their life, and they're seeing as kind of they're not diagnosed or anything, but it's just kind of for their own mental state, mental well-being, right? And they're maybe doing a weekly or a monthly meeting with a counselor. Like, do any of those have to be reported? And what is kind of the line of when those do have to become reportable?
As far as I know, all those have to be reported. But again, it's a discussion with your AME, that's who you're reporting it to. Just because it's therapy, though, it doesn't mean it's disqualifying. And the AMEs can still clear many things.
So in the directions on MedExpress, there are 3 things that are specifically excluded from a reporting requirement, and those are family or marital counseling and visits to the employee assistance program. So those are outside of it, but I encourage everyone to do health maintenance. And again, I'm standing on a soapbox, but a long-term relationship with good AME where you can discuss this will allow that AME to go ahead and issue the certificate. It may require a brief report from the mental health professional that you're seeing. Mental health professionals very appropriately want to protect your privacy, so they tend to write what we call a mother may I note. I saw Johnny Pilot and he's doing fine. Well, that's not enough for the FAA. They want to know what he's being seen for, what impact it has on their functional ability, whether they're taking medication or not, what the long-term plan is for therapy. But in general, a note that is a little bit more robust than what most mental health providers will give the pilot is very satisfactory to both the AME and the FAA. Mark, do you want to?
Yeah, I think maybe you're alluding to the fact that they have to report it immediately, or can they wait until their next medical to do that? You know, I think, you know, that could be potentially a gray area depending on what the diagnosis is. If it's just your maintenance type counseling, I think they can wait until their next medical and report it as we talked about on 19. But if there's something that rises above that and they're having some issues with depression, anxiety, or whatever, that may be something that needs to be reported sooner rather than waiting 2-3 years till they do their next medical.
I might add certainly if it's 2-3 years till your next medical, but if it reaches the point where you're getting regularly scheduled appointments, that might be the time, you know, if you're seeing somebody every week or, you know, things like that. And there too, even if it's for family stuff, I certainly prefer when somebody sends me a note or calls me and says, hey, just wanted to let you know this is going on, we're doing okay. You know, sometimes I'll ask, depending on the nature of it, hey, can you just have them, you know, would you be willing to sign a release? Can I just have a conversation with them? And usually it's just, hey, these are my concerns from a safety perspective. These are the things I'd like to know about. You know, this is where I'm coming from. Can we agree to stay in touch if any of these things arise? And that's where we go.
I was going to add too, we're literally, I had a meeting about this yesterday, and maybe I'm jumping the gun with a preview with what my boss will talk about tomorrow, but next month we should come out with a disposition table on what we call the V codes. So V codes are, if you guys are familiar with the Diagnostic Statistical Manual, DSM-5, V codes are in the back. They start with Victor, right? That's what they call V codes. A lot of those involve just psychotherapy. It could be a parent-child relationship problem. It could be bereavement. Some of those V codes, though, individuals will be prescribed medicines. So we just finalized a draft that, like I said, we should be coming out next month, that allows the AMEs to clear those, depending on the history and the type of medication usage, and allows individuals to get, it may have been over treatment, or maybe it was appropriate treatment, but now that they've stabilized, and they may still be in counseling for an issue, and still be able to clear their next medical, basically.
Yeah, and also we're here talking about peer support. Peers are not mental health professionals, and that's not a reportable visit. So the whole concept of a peer support program is designed to reduce the barriers to seeking help. And I'll talk about it a little bit later, but in most situations that come up, everyday life things that happen, I mean, there's never been a college student who hasn't had a breakup, and going through the grief of that. That can be resolved by a peer, and about 80% of the time, the discussion with a peer is adequate to resolve that question, and that's not reportable.
In this context, I have frequently told pilots, like, I'm not asking for perfection. Like, I don't expect perfection. If you tell me that you've never had any of these problems, or if you tell me that your parent has died and you're doing totally fine, or that you're going through a divorce and it's not affecting you at all, frankly, I don't believe you. Like, that's unrealistic. And same thing with folks struggling with addiction. Like, you're going to have some problems. It's not all going to be perfect. You're going to have cravings. You're going to have ups and downs. What I'm hoping for is that you'll be honest with me and you'll call me when you're having problems, or if you're struggling with this, and let's get you some more resources. That to me is more realistic, and I think that's the part that that's a good relationship with my HIMSS patient, is when they call me and they say, hey, I'm having anxiety about this, or I'm afraid to leave the area because I'm afraid of the drug testing, and I really want to get flying and I just don't know what to do, and I'm like paralyzed by this whole program. Like, those are the good HIMSS relationships. Like, let's work through these together. The ones that come in and say, nope, everything's perfect, I'm not having any issues, I'm ready to fly, it's like, I'm not so sure that this is, like, let's have some more conversations about this, because there's more probably beneath the surface. So I think we have to be honest about, you're going to have ups and downs. You're going to be depressed. You're going to be anxious. Like, that's normal life, and I believe that. And I'm actually happy to qualify you to fly, within reason, if we talk about these things.
I would also add something to what you just, because part of your question, I think, was when do you report it, or how? Right.
Yeah, so at what point does it become like one of those mandatory reportables? Or so, for instance, let's say that they never got diagnosed in those counseling sessions, right? It was they broke up with their girlfriend, they had some issues, in the familiar relationship back home, or they're having trouble adjusting to college life. Like, when does that become one that needs to be immediately reportable or reportable on the MedExpress?
So I would always go back to the basics of the I'm Safe checklist and 6153, right? Obviously, maybe as a student pilot, you may not have practice with making that self-judgment, but if you can unequivocally say, yeah, maybe while I've had this argument, I'm not okay to fly for the next couple of days, you don't call your AME, you don't tell the FAA, right? But depending on if you're on regular therapy visits for it, you would still ask yourself that same question. If you can say, I'm okay, I would wait until the next AME visit, just like what you suggested. But if you're not sure, that's when you should call an AME. That's what I always tell my pilots when I was an AME. Just, if in doubt, give me a call. We can discuss it over the phone even. It doesn't even have to require a visit. And then the AME can help you to decide, is this really rising to the level of something that maybe is, besides the fact that it's reportable, we're more concerned about getting the right treatment if it's an undiagnosed condition that's smoldering, basically.
And that goes back to kind of that consultation we talked about earlier, right? Cool. I think we had someone from the audience who had a question.
Yeah, hi, thank you. Some of the things that you were saying brought up some questions for me. So there's a lot of stigma around going to get therapy, and I think for me, when I listen to students talk about it, or just others talk about getting therapy, there's a big reportable type of fear that if the FAA sees that I'm getting therapy, then that makes me look a certain way. And from what I'm hearing you say, that's not necessarily the case. You want people to report it, doesn't necessarily mean that they're going to have their medical taken away or needing a special issuance. What about when you're talking about peer-to-peer programs? What about coaching for skills to help with stress? Those aren't necessarily therapy sessions. But you are going to sort of seek counseling on a skills basis to increase these types of things. Are those seen as different? Is that more peer-to-peer support? And then also I have a question, whose responsibility is it to report? Is the care provider expected to report and know what the FAA is looking for? Should we be encouraging students to seek help from someone who's aviation familiar? Or is it just anyone? You talked about the Mother May I letter. How do students go about asking for the type of reporting that they need from that provider?
So, I mean, the first part of your question had to do with peer-to-peer support, other types of coaching. I typically don't see those type of records, so that's not something I would consider as reportable at all. We want individuals to be successful, right? So those kind of things we wouldn't see as strict medical visits and a report in the 8500. Getting towards, I think your second question had to do with more, is there a reportable requirement on the practitioner side? That opens up a whole arena of, okay, look at your state's TerraSoft laws, because there are reportable requirements according to each state under TerraSoft if there's certain types of harm or self-harm requirements. That's irrespective of the FAA. But outside of that, there's no strict requirement that the practitioner report anything to the FAA. The only time I see that happening is when the pilot themselves wants their notes sent to their AME or to the FAA, then they sign a release with the practitioner. I have had community psychiatrists and community psychologists contact me having a concern about an airman or a student pilot, and I discussed with them what the whole case and whether they should file like an anonymous report with FAA. That's a whole new level of concern though, and it's usually not an acute safety concern, otherwise they'd be intervening much quicker, but it's usually a concern about falsification, right? This airman's trying to hide their past diagnoses. Now they're trying to go off of a FAA acceptable SSRI when we want them to stay on it, and we could actually certify them if they stayed on it. And the practitioner is having ethical conflict about this, knowing that this person is wanting to fly or is actually actively flying while taking a disqualifying medication. So I'm not sure if that answered your second question very well.
Yeah, I think the other part of your question is you were talking about life coaching and success, and Mark Larson is sitting back there. He hosted a panel at the recent NBAA convention, and Dr. Northrup, the federal air surgeon, was on that panel, and she specifically stated during that period of time that life coaching is not reportable.
Perfect, thank you. So we have another question that kind of ties in with that, and I'm going to read it word for word because I don't want to get any of it messed up. So, as an administrator in a collegiate flight training program, how should we handle a situation where a student holds a valid medical, but we now have knowledge that the student has discussed past suicide attempts or ideations to other collegiate personnel? How do we get that information to the AME or FAA without violating FERPA or any other confidentiality regulation?
I mean, technically speaking, they're not violating HIPAA themselves because only medical providers are bound by HIPAA. So it's other ethical considerations within the, I guess, campus or privacy, whatever privacy, I guess, regulations the campus has on those things, and trying to maintain some level of respectable confidentiality. I would say when there's something with regards to suicide, that is something that we would consider reportable to the FAA. It's an acute safety concern, right? Irrespective of flying, we get concerned when individuals are struggling with suicidal ideation. The question is, how do you get them to help? And you want them to be part of that endeavor. So having maybe a conversation with their close friends or getting family involved.
Yeah, maybe this is the unsaid part, but I would first of all make sure that we're having a conversation with them. I mean, first and foremost, treat it as a human issue and sit down with the individual and address it directly, and involve mental health and medical services. I think on the FAA side, we would want to at least have it reported and investigated from a safety perspective. And I think that that's important from an occupational safety perspective and a flight safety perspective.
And also, we're going to talk about peer support. I know that's one of the big concerns in peer. Captain Bernskotter from FedEx is back there, and she teaches a session on this, on suicide identification and suicide risk. And in the peer support environment, there are certain situations which require violation of that confidentiality. And it's very important for a peer support program to have a written escalation policy so that if there is a health or life-threatening situation, those are the primary concerns. as both my colleagues have talked about, we want that person to be safe, we want that person to be healthy, and there may be situations where a written protocol will be helpful in identifying those circumstances where it needs to be escalated to a level both of health and also of safety, which may get the person in for treatment, but also remove them from the flying schedule in the interim.
And this is a situation that is not that infrequent. We've had conversations with the safety office with Brian, where they maybe become aware of a situation that has not been reported, obviously. They may have stricter safety standards and put someone on a flight hold, at least for UND. They still have a valid medical. They could fly anywhere else if they thought they could get away with that. But in those circumstances, I think it's a reasonable thing if there's a known situation that they should get up. As we talked about before, it's always best if the airmen contact the FAA and let them know versus them finding out a different way. So that's one of the things we stress. If we see them, that we always encourage them to contact the FAA. It comes off better that way. And in those situations, we've had conversations where they have a concern, and it would be best if they would come in and see us. And even short of contacting the FAA, if they at least come see their AME, then we can talk about what we need to do and kind of go from there. But there have been situations similar to that, and you bet, talking to the AME and contacting the FAA potentially is a good idea.
Perfect. And I think
Mark, unfortunately, that concludes our time on the panel that we have allotted. I know we have a lot of questions left over online. We will certainly pass those on to our panelists to get answers later. We still have 2 more days of discussion, so I'm sure that these questions will be answered at some point. But let's give a round of applause for our panelists, and we'll start the research panel in 15 minutes or so.